there, let's solve some questions on the systematic assessment of ECGs. Solving these questions will hopefully help you to have a better understanding of what the systematic approach of solving ECGs would be. So let's look at question 1. Question 1 asks, what are the steps in the systematic assessment of an ECG? So the key to ECG interpretation is having a consistent approach. So every ECG should be assessed in the following order. So first thing, patient identification, then standardization, rate and rhythm, P-wave morphology, PR interval, QRS complex, including its width, height, axis, and Q waves, followed by assessment of the ST segment, T wave, and finally the QT interval. So using the same sequence every time helps prevent important abnormalities from being overlooked. Let's look at question 2. So what is the first item that should be checked during ECG assessment? So before interpreting any ECG, always confirm the patient's identity. Interpreting the wrong patient's ECG can result in serious diagnostic errors, and making patient identification the first and most important step is very important. So let's look at question 3 to question 8. So for question 3 to question 8, to answer all of these questions at once, we can look at standardization. So the standard ECG paper is 25 millimeters per second. At this paper speed, one small block represents 40 milliseconds or 0.04 seconds. So 5 small blocks represent 200 milliseconds or 0.2 seconds. And one large block also represents 200 milliseconds. So the same as the above. And 5 large blocks represent 1 second, therefore there are 300 large blocks in 1 minute. Understanding these values is essential for accurately calculating heart rate and measuring ECG intervals. Let's look at question 9 and 10. So heart rate. For regular rhythm, calculate the heart rate using the formula. So the heart rate equals 300 divided by the number of large blocks between consecutive R waves. For an irregular rhythm, count the number of QRS complexes in a 10-second rhythm and multiply that number by 6. Now let's look at question 11 to question 13. So we're going to be solving all the questions that are similar. We'll solve them collectively. So from here, question 11 to question 13. So P-wave morphology. So the P-wave is best assessed in lead 2 at P pattern, P pulmonale pattern indicates right atrial enlargement, whereas P mitral pattern indicates left atrial enlargement. Please excuse my pronunciation. Recognizing these patterns allows you to identify atrial enlargement on the ECG. And question 14 and question 15. So for question 14 and question 15, a PR interval. So the PR interval represents atrial depolarization together with conduction through the atrioventricular node, commonly referred to as AV nodal delay. The normal PR interval ranges from 120 to 200 milliseconds. Now let's look at question 16 all the way to question 23. So now we're talking about QRS complex. So the QRS complex represents ventricular depolarization. A normal QRS duration is less than 120 milliseconds, with the preferred ventricular activation time being less than 105 milliseconds. A narrow QRS complex, however, indicates that ventricular activation is occurring normally through the specialized conduction system. A broad QRS complex is defined as a duration greater than 120 milliseconds. The major causes of a broad QRS complex include bundle branch block, ventricular rhythm, pre-excitation, pacemaker rhythm. Whenever you see a broad QRS complex, think of abnormal ventricular activation. Now let's look at question 24 to question 27. So here we're talking about QRS height. The amplitude of the QRS complex reflects ventricular wall thickness. For left ventricular hypertrophy, apply the Sokolov criteria. So the S wave in V1 plus R wave in V6 greater than 35 mm suggests left ventricular hypertrophy. For right ventricular hypertrophy, look for a tall R wave in V1. And supporting findings would include right axis deviation, T wave inversion in V1 to V3, and P pulmonale. These additional findings strengthen the diagnosis of right ventricular hypertrophy. Let's look at question 28 to question 30. So for this, the QRS axis. So the QRS axis is estimated using lead 1 and lead AVF. Determine whether the net QRS deflection is positive or negative in each lead, then combine the information to estimate the overall direction of ventricular depolarization. So a leftward deviation of the QRS vector is termed left axis deviation, whereas a rightward deviation is termed right axis deviation. Let's look at question 31 to question 39. So here we're talking about a pathological Q waves and myocardial infarction. So pathological Q waves usually indicate a previous myocardial infarction associated with myocardial necrosis. They develop as a consequence of transmural myocardial death. The evolution of myocardial infarction can be remembered in 3 stages: ischemia, injury, death. Common infarct locations include anteroseptal infarction, lateral infarction, anterolateral infarction, high lateral infarction, wide anterior infarction, inferior infarction. Remember that inferior myocardial infarction may also be associated with posterior infarction or right ventricular involvement. Let's look at question 40 to 46. So 40 to 46. So ST segment and T waves. Following assessment of the Q waves, evaluate the ST segment, T wave, and QT interval. The ST segment may demonstrate either ST segment elevation, ST segment depression. Common causes of T wave inversion include ventricular hypertrophy with strain, myocardial ischemia or infarction, bundle branch box, myocarditis, or cardiomyopathy. Peak T waves are classically associated with hyperkalaemia, although they may also occur during hyperacute phase of myocardial infarction. For question 47, QT interval. So after assessing the T wave, always evaluate the QT interval, as abnormalities may indicate the delayed ventricular repolarization and increase the risk of ventricular arrhythmias. Let's do one more question. So for this one last explanation, we'll cover all these last questions. So from these questions we can get a deeper question. Why is patient identification important before interpreting an ECG? So patient identification ensures that the ECG belongs to the correct individual, and this quite simply helps prevent potentially serious diagnostic and management errors. So to summarize everything we did here, and hopefully this helped in whatever way possible, and hopefully you can use this to help patients in the future one day when you're a doctor. And whenever you interpret an ECG, follow the same structured sequence. So patient identification, standardization, rate and rhythm, P wave, PR interval, QRS complex, axis, Q wave, ST segment, T waves, QT interval. And the reason for this is a systematic approach not only improves accuracy during examinations, but also forms the foundation of safe and effective clinical practice. Thank you so much for watching. If you found this walkthrough helpful, consider subscribing for more high-yield medical school past paper discussions, and I'll see you in the next lecture, and Hopefully this helps, and hopefully you can share, and hopefully you can help others, because that's literally our purpose of studying medicine, to help people. Bye.